Good morning, everyone. My name is Hervin Heeroo. I'm one of the registrars in the division of ENT at UCT. So my presentation this morning will be on lymphatic malformations of the head and neck. Consent was obtained from the patient, and all my content is referenced. So the case I'm presenting today is a 7-year-old male who was born with a right cervical lymphatic malformation, which was microcystic. Sclerotherapy with bleomycin injections was started from day 10 of life. He received 5 doses at 1 to 2 monthly intervals, to which poor response was noted. He was started on sirolimus at age of 1, with monthly serum trough level monitoring with dose adjustment done. Some response was noted. Sirolimus was stopped at age 2 years due to poor feeding and sleeping. The patient was referred to ENT at the age of 6 years for resection. So a CT scan was done, and it showed a lymphatic malformation occupying the right neck, extending to the superior mediastinum. Encasement of the subclavian vasculature at the root of the neck was noted. So the resection was done under general anesthesia. A transverse hockey stick neck incision was made midway between the angle of the jaw and the clavicle and extended laterally and medially to the midline. Systematic dissection was done from anteriorly to posteriorly and then inferiorly, starting along the anterior border of sternocleidomastoid. The lesion was dissected free from the carotid sheath while preserving the vagus nerve. The lesion was next dissected off the internal jugular vein and followed down to the root of the neck. The right subclavian vein was preserved, and the deeper mediastinal component was left behind. The accessory nerve was preserved. The lesion was peeled off the brachial plexus. The specimen was sent off for histology. Blood loss was minimal. Excess skin was excised. A piccolo drain was inserted, and the wound was closed in layers. Histology confirmed a lymphangioma. These are pictures taken 1 month post-operatively. The patient was restarted on sirolimus post-operatively, and he attends our clinic monthly at Red Cross for serum trough level monitoring. According to the classification of the International Society for the Study of Vascular Anomalies, lymphatic malformations are low-flow vascular malformations resulting from abnormal embryologic development of regions of the lymphatic system. They're found in the head and neck in 75% of cases, from where they may extend into the thorax. With an overall incidence of 1:5,000, lymphatic malformations account for 6% of all pediatric soft tissue masses, and around half are diagnosed at birth and 90% by 2 years of age. Theories of lymphatic malformation development include failure of the lymphatic system to adequately separate from or connect to the venous system, giving rise to cyst formation and lymphatic accumulation. Secondly, abnormal sequestration of lymphatic tissue in embryogenesis. Thirdly, anomalous budding or sprouting of lymphatic structures from the cardinal vein. The lymphatic malformation mass is composed of lymph-filled cysts. A lesion comprising cysts greater than 2 cubic centimeters in volume is macrocystic, whereas a lesion with cysts less than 2 cubic centimeters in volume is microcystic. However, most lesions are mixed and have both macrocystic and microcystic components. Historically, macrocystic lymphatic malformations were often called cystic hygromas, and microcystic lymphatic formations were called lymphangiomas. In 2015, Longstreet and colleagues proposed an anatomic classification of fetal nuchal lymphatic anomalies. They recognized 3 groups of fetal lymphatic malformations: nuchal thickening, dorsal lymphatic malformations, and ventral lymphatic malformations. Nuchal thickening is a hypoechoic region exceeding the 95th percentile between skin and soft tissues bordered by the fetal spine and occiput. About 30% of these lesions are associated with chromosomal abnormalities such as trisomy 21, trisomy 18, and Turner syndrome. 80% of these resolve by birth. Dorsal lymphatic malformations are septated, fluid-filled, multilocular cavities extending along the entire dorsal length of the fetus. These cavities are associated with a high percentage of other abnormalities, such as cardiac, renal, and skeletal. Many of these abort spontaneously or electively. Of those that survive, 50% resolve spontaneously. Ventral lymphatic malformations are defined as those occurring on the anterior and/or lateral cervical region of the fetus. They are at risk for airway obstruction and may necessitate an ex utero intrapartum treatment, also called an exit procedure. Superficial lymphatic malformations present as soft bulges with or without overlying skin discoloration. Mucosal lesions often involve raised white or dark purple vesicles that can leak chyle or blood. Deep lesions abutting the airway may cause airway compromise, and deep lesions abutting the esophagus may cause dysphagia. The most common subsites of airway involvement are the oral cavity, oropharynx, and hypopharynx, while glottic, subglottic, and tracheal involvement is comparatively less frequent. In a review of a large series of cases in Norway, clinical symptoms included the following: asymmetry or disfigurement, 48%, pain and or discomfort, 20%, exacerbations, also intralesional infections, 15%, airway issues, 13%, functional disability, 12%, bleeding, 11%, and lymphoria, 6%. Differential diagnoses comprise congenital cysts, thyroglossal duct cyst, ranula, thymic cyst, branchial cyst, bronchogenic cyst, or digestive duplication, and vascular abnormalities in children, and cystic metastasis of tonsillar or thyroid cancer in adults. Rapid growth of cervicofacial lymphatic malformations may lead to significant clinical sequelae, including airway obstruction requiring emergency orotracheal intubation or tracheostomy, functional issues such as dysphagia, speech impairment, dental problems, and neuropathy, secondary to compression by large lesions that can cause pain and paresthesia. Deformity may lead to significant social ramifications and psychological distress as the child becomes older. And lastly, hemorrhage and infection. One of the clinical hallmarks of lymphatic malformations is their tendency to exacerbate and then remit. Exacerbations usually occur in association with upper respiratory tract infections, but they can also occur after trauma. During these episodes, the lesions become firm, inflamed, and swollen. These exacerbations can last 10 days to 12 days. Blood cultures are usually negative, and there is often no direct evidence of a bacterial infection. Despite this, antibiotics have formed the mainstay of treatment, and adding corticosteroids usually reverses the symptoms and shortens the course of the exacerbation. Diagnosis is usually made on clinical presentation. In the absence of obvious features, MRI with and without contrast is needed. Lymphoid macrocystic and or microcystic lesions are the main diagnostic features. Hemorrhage may result in a fluid filled level in one or more of the cysts. And because the lesion is made up of a large component of lymph, the lesion shows a high signal on T2 weighted images. Gadolinium enhancement is seen in the interstitial spaces between the cysts. Microcystic lesions show a hyper-intense homogeneous T2 image. Ultrasound imaging usually shows a heterogeneous mix of cysts separated by echogenic septa. In case of diagnostic doubt, especially in lateral cervical or floor of the mouth lesions, fine needle aspiration cytology can be contributive for diagnosis. Several classification systems exist based on location. The simplest is the dichotomous type 1 and type 2. Type 1 lesions are found below the level of the mylohyoid muscle in the anterior and posterior triangles of the neck. They are often predominantly macrocystic and have a better prognosis. Type 2 lesions are found above the mylohyoid muscle, involving the oral cavity, cheek, and parotid regions. They are more microcystic and carry a less favorable prognosis. The most common classification that is used is the 1995 classification by De Siris and al., which groups lymphatic malformations according to head and neck location with respect to the hyoid bone and uni or bilateral involvement. Both the risk of complications and recidivism rate increase with advancing stage. There's also Berg's classification that focuses on laryngeal locations with 4 grades. It enables prognosis in treatment, and grade 3 and 4 are noted to correlate with high rates of tracheostomy and decannulation failure. Wigan's classification grades microcystic lingual lesions for prognostic purposes. It comprises 4 grades according to extension and infiltration depth with prognostic value. The colloid disease score grades severity of signs from 0 to 2 with a total score of 10. 0 means severe and 2 means absent, with 5 items: respiration, feeding, phonation, aesthetic aspect, and progression. The lower the grade, the more severe the impact, and the poorer the quality of life. The lymphatic malformation function instrument is a classification based on parental assessment of the impact of the child's head and neck lymphatic malformation. It comprises 12 items rated 0, meaning never, to 2, meaning most of the time, out of a total score of 24. And the higher the score, the more severe the impact and the poorer the quality of life. The treatment of lymphatic malformations is best undertaken by a multidisciplinary team, which includes pediatricians, ENT, general pediatric and plastic surgeons, as well as ongoing psychosocial support. Treatment modalities include observation, surgery, sclerotherapy, and medical management. The risks and benefits of conservative management should be considered. According to Perkins and colleagues, conservative management is appropriate in a select group of cases because a percentage of these lesions spontaneously shrink. This includes patients in whom the lesion seems to have disappeared and in whom there are no other sequelae or complications. Conversely, Hassanein and colleagues found that in 85% of kids with lymphatic malformation, the lesions expanded and or became symptomatic during childhood. Sclerotherapy is often used as a primary modality for treating lymphatic malformations, and commonly used sclerosant drugs include bleomycin and OK-432, also known as PC-Banil, sodium tetracetyl sulfate, doxycycline, and dehydrated alcohol. In a systematic review by Acevedo and colleagues of patients treated predominantly with bleomycin and OK-432, 43% of patients had an excellent or complete response, whereas 45% had a good or fair response. And Balakrishnan and colleagues showed no significant difference in efficacy between surgery and sclerotherapy. It is now known that macrocystic cervical lesions respond well to surgery and in most cases can be completely excised, whereas the likelihood of complete excision of a microcystic cervicofacial lesion is extremely low, and therefore the risk of recurrence is high. Meta-analysis by Heeroo and colleagues found that surgical recurrence rates are around 30%, whereas the morbidity is between 2% and 6%. Results of studies in which sildenafil was used to treat lymphatic malformations are mixed, with some showing improvement and some worsening. And in a case report from Red Cross Children's Hospital in Cape Town, Rock and colleagues found no regression of disease with sildenafil use. Sirolimus is a specific inhibitor of mTOR, the target of rapamycin, which is a key factor in the regulation of angiogenesis, cell growth, and proliferation. Sirolimus has been found to be an effective treatment in children with large, complicated lymphatic malformations of the head and neck. And in a systematic review by Wigan and colleagues, more than 91% of children responded to sirolimus treatment, which lasted from 6 months to 4 years. The most frequent initial dose was 0.8 milligrams per square meter per dose, twice daily at 12 hourly intervals. Target blood levels were 10 to 15 nanograms per milliliter and 5 to 15 nanograms per milliliter. Those were the target blood levels that were most often used. Typical side effects were hyperlipidemia, neutropenia, and infections. Lymphatic malformations of the head and neck, in conclusion, require a multidisciplinary approach. Optimization of function and cosmesis must be balanced with minimization of treatment associated with morbidity. In conclusion, more research needs to be conducted for diagnosis and management of these lesions. These are my references. Thank you.
Thank you very much. I'm going to ask you just, now this patient specifically, do you think the management has been appropriate with sclerotherapy, or do you think one should have gone for surgery earlier, using your reading? Any here?
Hervin? Hervin?
Oh, there is communication.
Can we please ask Dr. Katundu? He's our PIDS ENT fellow at Red Cross to comment. Dr. Katundu?
So, dear Prof, can you please get the question again?
Hervin, can you hear us?
Hello. There any question for Hervin if I may some comment?
Not to be that he's got his volume down.
No. I can type your question, Robert.
Hey,
I can type your question.
I think we could probably finish the okay. Maybe once you just sit down, just take the system coming out. Yeah, okay. It's working.
There's a comment from Dr. Arnold.
That is surgery and
So the patient was initially discussed with surgical resection, plastic surgery, and ongoing conservative management is recommended for within this restrictions of possibly 80 surgery.
I see, okay. So they could hear the question. Well, thank you very much. Thank you.
Thanks everyone for joining us. We'll meet again on Friday when I believe.
Friday, is it? Yeah, I think so.